All right, so now that Keats has given us some different techniques to think about and play with, obviously he showed you on my right forearm those techniques, but they can be applied to any muscle in the body, anywhere. So, feel free to practice those on your clients or your coworkers so that you get familiar with those techniques and get comfortable doing them on a whole bunch of different structures. Right now I wanted to just discuss some of the ideas as far as thought process is concerned with this whole site versus source pain phenomenon that we have. In the article I talked about lateral ankle sprain, or what's sometimes called an inversion sprain, and how that can affect the lateral line of the body. And lateral line is kind of an idea that's proposed by Tom Myers, a rolfer, and he talks about some of these fascial connections that we have going on. And the book has been really popular in the strength and conditioning community and in the massage community, and some of the strength coaches read it and then they think about it and they think it's very interesting, but then they don't think about how to apply it, or they don't apply it, rather just noting that it's kind of interesting. So this thought process may be able to help them out as far as figuring out ways to put this into practice. So just to review, when we think about the lateral line, we think about our peroneal muscles, which are the muscles on the outside of the lower leg here, which are, peroneus longus comes all the way underneath the foot, helps to create that sling with the posterior tibialis, and creates pronation or eversion of the foot and ankle here. So obviously in an inversion sprain, it's put on a very rapid stretch. So we start with the peroneals, we move up to the IT band, which everybody is familiar with, and then the IT band kind of turns into the glute maximus and the TFL, and part of the glute medius, although it attaches onto the greater trochanter here, part of that can kind of feed into the IT band near the top portion, where sometimes it's called the gluteal fascia. From there, at the iliac crest, where these muscles kind of come up, the glute max kind of comes up, we get into our connection with the QL, which is a very deep muscle here in the lower back, and then that kind of moves on up into the intercostals, the obliques, all the way up. We get into some serratus, some scalenes, and some SCM. So obviously you can see the connection from the foot to the ankle, and I know we're talking about ankle sprains, but you can even go and think about this from the standpoint that maybe core dysfunction is what's creating ankle problems, or starting the person off with maybe learning how to breathing techniques because of the involvement in the intercostals and the scalene muscles. So just something else to kind of play with and think about. But the idea in the article, I talked about working proximal to distal. So starting with the muscles up at the hip, starting with the QL, and then working downward. And sometimes you'll find that actually working down to the ankle, it feels better without you even having to work on it. In addition, if this were an acute situation where we might not be able to get in and work on this ankle because maybe it's there's a lot of swelling going on, a lot of inflammation, it's very painful, it would be contraindicated for us to go in there and start working on it. Working on these proximal muscles can help move some lymph and blood flow and hopefully get some of this swelling down, as well as just keep these muscles healthy while the person navigates a way of walking that keeps them out of pain or semi-out of pain. So we can take any of Keats's examples, apply them to any of these muscles. So for example, the QL, we know it has some attachments here onto the 12th rib and the lumbar vertebrae L1 through 4 on the transverse processi. We can feel his erectors, and we can kind of come in right around the side of those erectors and sneak in right underneath the 12th rib. And all I'm doing is using some of that ischemic compression. And one of the ideas that Keats talked about in the article is the idea of satellite cells, or satellite trigger points, I should say. So the QL we know can refer down to the outside of the hip. We know the TFL can refer down the leg. Any of these areas where they refer to and create pain can also be prone to creating trigger points, trigger point development, similar to the pectoral muscles being very tight and housing trigger points and creating satellite trigger points in the upper back muscles and the rhomboids, and making the upper back very tender or tight. So when we look at this lateral line, we can work through the QL, we can work onto the iliac crest, we can move down into the glute max, which is the largest, more superficial. It's going to cover over a portion of the glute medius muscle, which lies deeper to it. So you might have to compress a little bit more in order to affect that tissue. And it attaches onto the greater trochanter. But like I said, some of the fascia gets into the IT band here. Our TFL, we know that if we find his ASIS, the prominent bump on the front of the hips, if we kind of drop right behind that, we can find the TFL. We can friction any of these muscles. If they're very painful, we might just use some ischemic compression. Any of the techniques that Keats talked about, obviously the IT band, we can work down there with gliding strokes. We can use some of our skin rolling techniques that Keats showed you. And then once you get down to the fibular head, where the peroneus longus starts, you can work again, stripping down those muscles with any of those techniques that Keats showed you. Like I said, if it's an acute situation, you probably want to stay more proximal instead of working down into the distal area. But if the person is coming back from the injury, let's say they're cleared from physical therapy, they're ready to come back to sports activity, they're ready to start training again, and they may still complain of ankle pain, or maybe they feel weak, or maybe a little tentative on the ankle. Searching for some of the trigger points in these areas and helping to get this tissue more compliant may help with some of the pain down here. Because, I believe Keats talked about it in his article, but sometimes we develop trigger points as a way of, as a strategy, for our body. They're more of like a protective thing. They're used to stabilize structures. So if you think about in this ankle sprain situation, when the individual had pain and was unable to walk, or was trying to put less pressure on the ankle, or maybe they were in an immobilization boot, their strategy for walking, their strategy for gait was to use some of this QL to hike the hip, to use some of these muscles to change the function of what's going on down here in order to move us out of pain. And now that the individual is ready to move back into sports activity, those trigger points are obviously going to be undesirable or unhelpful in allowing them to get back to normal function. So I encourage you to look at Tom Meyer's work, look at some of those lines as far as how they connect even up into the upper extremity, and just think about some of the injuries you're working with, and develop your own thought process for how to treat the tissue, or how to determine maybe the best approach to finding the site of the pain, the source of the pain, and not just working on the site.